Welcome back, my friends, to another episode of the ASAP Pathway podcast. I'm your host today, Dr. Stacy, and I have my friend Dr. Ben Miralgia with us today. I'm so happy. Hey, Ben.
How are you doing, Stacy?
I'm doing good. We're laughing probably because we've been talking for about 20 minutes before we even started this conversation, just catching up, and it's been so nice. And I've just known Ben for years. We've just kind of been on a similar journey. I think you were ahead of me in the pediatric for sure aspect, but it's been fun to watch all the stuff you're doing and how you've evolved on your journey, and I've evolved in mine. And I'm just so happy to know you and to have this time with you today. And I want people to get to know you and who you are and just have some conversations.
That sounds wonderful. Thank you very much. It's an honor to be here. Yeah, happy to see you.
How wonderful. I'm just so happy you're here too. So for those of you who do not know Dr. Moralia, I'm gonna introduce you. I always say Moralia. Is the G silent?
It is. You got it right. That's
Okay,
perfect.
good, because
Miralgia.
I've always said it that way. Okay. All
Yeah.
right, here we go. Dr. Ben Moralia graduated from the SUNY at Buffalo School of Dental Medicine and brings 31 years of general practice experience from Mount Kisco, New York. Over the past 21 years, his work has focused on interceptive orthopedic and orthodontic treatment, emphasizing early childhood growth and development. He is a national lecturer on sleep disordered breathing, clear aligner therapy, and craniofacial development. He currently serves as the Chief Clinical Officer at both Airway Health Solutions and Tooth Pillow, as well as the Vice President of GP Clinical Education at Candid Pro. Additionally, he sits on the board of directors at the American Academy of Physiological Medicine and Dentistry. He's recognized multiple times as a leader in continuing education by Dentistry Today magazine, and he remains committed to advancing dental education and promoting airway health. So, with that being said, welcome and let's have
Thank
a
you.
conversation. So,
Yeah. Let's have some fun.
okay, so I'm going to go back in our journey. I just remember, I think the first time I met you in person, I had heard of you in the community when I was transitioning kind of from just adult, OSA, sleep related breathing disorder management, had my own kids and thought, oops, no one's got solutions there. So
Yeah.
people were like, you got to go check out Ben Moralia. And you came to St. Louis to speak. And that was the first time I saw you speak, and I was super impressed. Um, and that was kind of my transition into pediatric sleep. And you were one of the people that I saw. Of course, there's Kevin Boyd and
Mhm.
Barry Raphael, all these guys that
Yes.
were really, implementing this, and I piggybacked on them
Hmm.
and their coattails. But you were definitely one of the other first people I saw, Marianne Evans, people like that. What's your journey? Like, how did you get into this? I mean, everybody listening to me yapping my jaws on the podcast, they know how I started, but how did you get here?
Yeah. So I'm 31 years in dentistry. I'm a general dentist. I spent the first 10 years fixing the teeth. 10 years of crowns and bridge work and implant dentistry, doing these reconstructive procedures. And over that time, as a family care practice, like you see the kids, they come through hygiene. Maybe you put a sealant on, you do a little filling, whatever, because they're there. Well, you have to send them out for ortho when they're 11 or 12. So for 10 years, I'm sending these kids over to local orthodontic specialists. And 11 to 12 years old, they get their braces. They're doing braces for 2 or 3 years. Sometimes it's 5 or 6. You don't know what's going on because we didn't learn much about it then. Well, you're watching it, and now you're seeing the kids because over a decade, you're seeing the kids you sent out come back every 6 months for a cleaning. You're following along. And it just was a building level of disappointment. And the building level of disappointment was that this is taking forever and it never looks good. Why are we extracting teeth? Like that was one of the biggest things. Why are we taking teeth out? Because I couldn't understand it because I'm looking in the mouth and I'm seeing mild crowding, if any, but they had this formula and math and tracing, and they were looking at this stuff going, we have to take out the teeth. It says to take out the teeth. And I don't see why don't we leave them alone? Like I'm thinking if you leave them alone, they're better off than taking. I just couldn't get it
That's
in
a
my
good
head. I
point. Just
couldn't
leave it alone with a little
just
crowding.
don't touch it. I think they're better the way they are. Don't touch it. And so I couldn't wrap my head around it, but it just was something that stuck with me and I couldn't stop it. Meaning like I knew it was wrong. This has to be wrong. I don't know why it's wrong. I just feel it's wrong. It has to be wrong. So I'm watching these kids. Extractions bothered me the most. The second thing that bothered me the most was having the TMJ or TMD problems because I'm watching these kids in braces that I sent, but I've had them in my practice for years. They don't have TMJ or TMD or headaches, but now they've got braces on and they're getting head and neck pain or having joint clicking and joint problems. And I could see, uh-oh, something's wrong because they didn't have that. Now they do. In my head, that adds up to the braces are causing a change in the joint or something's wrong. Then there's the spaces that can't be closed. The body's resisting certain stuff. Years are going by. All of this adds up to disappointment. So I start taking courses. So a little over 2 decades ago, I started exploring a different pathway because what I was seeing was so unpleasant to me. There has to be another way. I found expansive orthodontics. And so I was shocked because I thought there's only one way to do braces in orthodontists. You send them to a specialist and they do their magic. But meanwhile, it turns out there's a whole separate group. They're just smaller and they're quieter. But
Hmm.
there is an expansive orthodontic group out there. I start taking these early intervention, expansive orthodontic techniques, which don't focus on the teeth. They focus on the jaw growth and development early. And once I started taking those, then it all started clicking. So what I recognized early on was, hey, the orthodontic specialty is focusing on the teeth later. This group here is focusing on the jaws earlier. And that was like the first big piece of the puzzle that I knew, okay, there's a better way. There is another way out there. I just had to find it. And like you mentioned, Dr. Boyd, Dr. Barry Raphael, others like them were doing this already. I didn't invent any of this stuff. I was taught by mentors of mine that were out there doing it, but quietly and in small groups, pockets around the country.
Right.
Sure enough, I start learning early intervention as young as 3 years old. We can help and make an impact. And then you come across the techniques that are involved. You start learning the why you want to do this earlier, and you grow the jaws because that's your cause versus treating the teeth later. That's your symptom. So the teeth are a symptom later. And how successful are you going to be if you treat the teeth later when the jaws are the wrong size? And what we know the outcome of braces really is they're going to shift back rather quickly for almost all kids. So it over the time I realized, okay, I'm heading in the right direction. I'm going to start treating kids earlier because I was so disappointed in the outcomes and the pathway and the opportunities they had later. And it just took off so fast. The parents were so hungry for alternatives that I had to stop doing restorative dentistry. I had done a decade of all of this incredible, beautiful restorative dentistry, and then I no longer wanted to do it because once you treat one child and help
Hmm.
one child with their growth of their jaws, which downstream we're going to talk about symptoms
I
later,
was
but
just gonna say there's more
oh
to
my
it.
God,
Yeah, there's
once you
more to
heal
it.
one child, you have to heal them all. Then you want to help them all because you know if they go for the alternative, they're not going to get helped. They're just going to get basically knowing 2 decades later, the traditional braces model at age 11 or 12, it only offers you straight teeth temporarily. That is it. You can have straight teeth temporarily from braces later at 12 years old. But when you work on the jaws earlier, you get a different pathway and a different outcome. And that's where this whole call is going to go or conversation is going to go.
Yes. And the thing too, it's, just going back a few things, um, nobody's really looking, I shouldn't say no one. Very few dental healthcare professionals are comfortable with the joints. We get a little bit of it, right, in dental school, not a whole lot. Wish we had more. Wish we had more sleep and breathing, which hopefully that is changing. And, those go hand in hand. But, something you said too, we have to look at the jaw joints and whether, just to like give a disclaimer, whether the braces are actually causing the joints to click or the timing in which that age group, that 11 to 13 age group, where the symptoms could be emerging because they're being missed earlier, because they are We're not addressing the bone. We're not addressing growth and development. We're just spinning the white things around. So then they get these braces on and now they got a click. Maybe they would have had the click without the braces too. I'm not 100%, but we know that what's going on. And the bottom line is the braces aren't totally addressing the click, especially if you're not looking at the bones, the position of the jaw. And unfortunately, it's not taught a lot, even in orthodontic school. I have some, I'll just throw out Dr. Masmo Sherry and Suka in town. They are amazing. And they do look at jaws and growth and development, but not many orthodontists are. And again, we're talking about how they focus primarily on, just so we have people in the audience that are patients or lay people or even medical and they don't understand dental. In fairness to the orthodontist, the majority of their training is, it's in usually in they're in like either a hospital location or they're in the dental school location, and they are seeing a demographic of kind of that 11, 12, 13, 14-year-old age. They don't even really see the small children in orthodontic residency, which a lot of the orthodontists that are bravely emerging with what you and I are about ready to talk about is when you start to see interception earlier, you see a lot of changes in health even downstream. And so
Yeah.
the orthodontists that are saying, wait a minute, I've had them on and they're like, look, it's not that orthodontists don't want to help. It's just that's not what we're taught. And we don't see these little kids. We're seeing them later in life. And there's just so much, they understand growth and development. They're just not intercepting early because the schools aren't teaching interception. The demographics aren't there to get the treatment. So, but back to what you were saying, when you help
Mhm.
one and you get out and you're out on your own and you start thinking, there's just this intuition as a healthcare provider when you see patterns over and over in your office.
Yeah.
And everyone, we throw around the word, evidence-based medicine a lot. But part of evidence-based medicine isn't just sitting there and waiting for literature to come out to tell you what to do. Evidence-based medicine is also what am I seeing anecdotally in my own practice over and over again? What are my colleagues seeing over and over again? When we're talking to each other at our study clubs or at annual meetings, what are the murmurs? What should I be open to? And then we need to ask further questions and maybe start researching that as well. So back to what you were saying, when you help one, you're like, okay, I can't unsee this.
Yeah.
What were you seeing? So you helped. What? Yeah, you created more bone. You, and then when you have more bone, the teeth stay straight.
Yeah.
They know where to
Stability.
go. They know where to go and they stay
Yeah.
straight. Like if you notice in your practice, I'll just mention mine, like these kids that actually have wisdom teeth, okay? They have room
Yeah.
for flipping wisdom teeth. I always
Yep.
I mean, they're such an enigma and so rare. And so
Yep.
when I look, I don't have to look at them and say, let me make you a retainer to keep your teeth straight. I don't. Their teeth will stay straight because they have
Yes.
plenty of room for their teeth. It's when we are moving them around and taking the ligaments and trying to turn them because they came in crowded because the bone was deficient. They're going to need a retainer because those ligaments have memory and they want to go back. But
Yeah.
let's go back. I get so excited. Tell me what you were seeing after that first interception when you went to one of your small groups that were interceding early.
Yeah, so we're starting out early 2 decades ago. We start treating children earlier, and the whole focus then was on the jaws. It was almost like ignore the teeth. Let's work on the jaw size. And as you start doing techniques earlier that help the jaws grow better, then the teeth would start to go where they belong without doing anything to them. So the dynamics became learning more and more and more over time. And then early on, another big piece of the puzzle was that the breathing and musculature has a lot to do with this. So I'm a big follower and believer and disciple of the anthropology research. So in my world, I live by Dr. Coracini, Dr.
Mm,
Rose, the anthropologists, the head and neck malocclusion type anthropologists who know, and Dr. Jameson Wallace is in there, and Weston Price is in there, the dentist who did a lot of stuff. They knew early on that, yeah, this is indisputable research that Or undisputable. Well, that's a good one. I probably got that word wrong.
I don't know, but I'm going to
But
look it up after because I didn't
I
even
know,
think
right now
anything
I
of
just
it.
learned something new today, which is the correct
Maybe
word.
they're both right. I don't know.
But basically, what happens is they learned early on that as soon as cultures that are natural or aboriginal isolated, which have a very natural living, as soon as they start to adopt that Western industrial early soft food, well, then the jaw muscles become weaker. Softer food doesn't require strength of muscle to chew and swallow it. It's almost like a drinking pattern instead. So mushy baby foods, softer foods, give you weaker muscles. And if the tongue is weaker, the jaws won't grow the same. When the tongue is weaker, it becomes dysfunctional, meaning it doesn't function properly. It stays lower. And if our tongue stays lower, the next domino that falls is that the lips and cheeks start getting involved to compensate for the tongue staying lower to help with the swallowing pattern. Basically, early soft food in an infant in that first year of life gives the musculature the dysfunction and weakness that creates the lack of jaw growth and development. We need proper strength and function in our muscles, primarily the tongue, in order for the jaws to grow. So as soon as we have this early soft food, the muscles are off. When the muscles are off, weaker and dysfunctional, the jaws don't grow the same. So we learned from anthropology research that malocclusion or a bad bite, crowded teeth, bad bites, however we want to call it, it's not genetic. It comes from our environment. We've changed the early food to soft. Now the muscles are weaker and dysfunctional. The jaws don't grow. When the jaws don't grow, you get crowded teeth. And it happens very rapidly, very rapidly. In just a few generations, almost all kids have underdeveloped jaws. Smaller jaws, crowded teeth, no room for wisdom teeth. So what do you see the pattern is? Almost all children need braces to fix their teeth and need their wisdom teeth out. It's very rare to find a child that doesn't need any braces, mean their teeth are perfect, and they'll actually keep their wisdom teeth too. All 32 perfect. Where's that child today? That's a unicorn.
That's a
So
unicorn.
so you learn about the muscles. Well, if the muscles are involved in our cause, then we want to work on those. So it's not just about forcing the jaws to be bigger. It's about let's regain the proper musculature. That's where the myofunctional therapy component comes in. Whether you're using expanders or guides or any appliance, really, whatever you're using, fixed, removable, it doesn't matter what the names or styles are. The point is that you're getting involved early and you're
Yes.
getting involved with appliances that can help the jaws grow, but also attend to the musculature. Some appliances include that type of opportunity, others don't, which means then you use the myofunctional therapy along with it. So
Right.
we start combining things like appliances to help the child with myofunctional therapy. Let's train the musculature. It's no different than going to the gym. You know, if you want the musculature, if you'd like the physique, you go to the gym, you work out the muscles. If you don't go to the gym, you lose it. You got to work out the muscles to have that bone grow nicely. So myofunctional therapy became a part of it. I didn't know that early on. 20 years ago, it was not something I learned first. I caught that after. So that jumped into the mix after. Now I know it's an absolute necessity for people to work on the musculature because you want to treat the cause. Ultimately, you want to treat the cause, not the symptoms.
Right. And
Treating the
that's what we're
symptoms,
seeing
oh,
is getting in early. You
yeah,
make such an impact. And I didn't mean to cut you off there. I'm sorry.
that's okay.
I just got excited. But it's the earlier we get in, the impact is so much greater.
Yep.
Like you said, 3, 4, 5, and that's really the age. You know, I was saying
Mhm.
this recently. I was speaking at Transform Dental Sleep in February, and they were, we were just talking about, how young can you get started? Really, if you look at a child where the first hiccup usually occurs, it can be they had a really bad cold as an infant and they never really regained nasal breathing. Um,
Mhm.
there was even, some of the, someone even mentioned to me too that, some of the flu vaccines, they were giving the nasal version and they were finding some nasal breathing issues after that too. And it's like, oh my gosh, I never thought about that. But um, you can have just this hiccup, this small hiccup,
Yep.
where a child converts from nasal breathing to mouth breathing.
Oh
And
yeah.
it could be enlarged adenoids or turbinates. It could be allergies. And if you
Hmm.
can intercept at that age and you see this little kiddo with a crusty nose or crusty lips because they're mouth
Yep.
breathing in your chair, and you look at the mom or dad and say, is this their everyday, their breathing, or is this
Yeah.
just, are they sick this week? But like you said, you got to get to the root cause. and we're just kind of like looking at this train wreck.
Hmm.
We're looking at the crash at 11, 12, 13, 14. And I know you have seen the papers. I mean, they're over 100 years old where, orthodontists and general dentists were saying, we can't wait till
Hmm.
11, 12, 13, 14. It's too late. You have to, when they don't have spacing between baby teeth,
Right.
that is the malocclusion, folks.
Yep, that's right. No
And
space.
so just
Perfectly straight baby teeth is actually bad
perfectly
for
straight
us.
baby teeth
The
with no
jaws are too
spaces
small.
is a problem. But,
Yeah.
just those adenoids can be between the ages of, 3 and 6. It usually
Yeah.
starts as adenoids, but it's like, it could be a virus, hypertrophied
Hmm.
adenoids. They never went down. They're never going to go down. I don't know. Sometimes they can,
Yeah.
sometimes they don't.
Well, that's a big issue because that adds fuel to a fire. It's already burning. We look at that 0 to 1 year old who's getting fed the baby food, the mush, the purees, everything we do with the
Yes.
magic bullet. We think we're running to the farmer's market to get all this healthy food, but then we put it in a blender, we puree it, and we give it. Well, that's softer food, weakening the muscles, giving us the smaller jaws. That's where the breathing problem begins because our upper jaw, once the upper jaw isn't developing properly, the nose is too small. Our nose is the upper jaw. So it's not just holding our teeth in.
Yes.
So what a lot of people forget about is the maxilla, this upper jawbone, actually frames out the nose. In order to be a good nasal breather, you need a fully grown maxilla. So that early soft food with the weaker tongue, we're not getting the tongue up into the jaw to grow the maxilla. Well, if the upper jaw is not growing, neither is the nasal chamber. So if the air doesn't flow through the nose well, automatically the body opens your mouth. The mouth breathing is like a relief valve. It's like your body's CPR. So you're not supposed to breathe. We're obligate nasal breathers. A human being
Yes.
has to breathe through their nose. Nose breathing is healthy. Mouth breathing is the opposite. Mouth breathing is wildly unhealthy. And so as soon as we have that softer food and the weaker muscles and the smaller jaws, it begins the pattern of shifting from nose to mouth breathing because we can't breathe through our nose very well. The bone isn't big enough. Now, if the lower bone's not big enough, there's no room for the tongue. Both being too small means the nose is too small inside. I can't breathe well through my nose. And if there's no room for my tongue, it has to be further back because when I close my mouth, the tongue is further back. It blocks the air. We're creating this condition of I have to breathe through my mouth now. It's the mouth breathing that brings on the tonsil and adenoid size. That's another perception issue I like to get out there for parents to understand. The tonsils and adenoids being big didn't cause your breathing problem. The breathing problem caused the tonsils and adenoids to be big. There's two pathways. Number one is mouth breathing alone is an irritant. The air coming in the mouth is not filtered or cleaned or humidified. So it hits the tonsil first at the back of the throat and it backs up to the adenoid, which is above it. But when you nose breathe, the air goes through a chamber. It's filtered, warmed, humidified, and accelerated before it even gets to the adenoid. The nose is totally prepared with the nitric oxide being added to it. Then it gets to the adenoid and goes by that and by the tonsils last. When we flip that and do it the other way, breathe in our mouth, it irritates that tissue. It starts to get a little bit swollen or irritated. But the second reason is the more important one. Nose breathing comes from the brain signaling the diaphragm. And when the diaphragm is going down, we'll breathe in because the diaphragm moves down, we bring the air to the bottom of the lung. When the diaphragm goes up, it pushes the air out. Diaphragm breathing is really where you get your beautiful breathing from. But what happens is when we start to mouth breathing doesn't require the signal from the brain to the diaphragm. Mouth breathing usually comes from chest muscles expanding and contracting. The big problem is when we are breathing through our mouth and the chest is expanding and contracting, the diaphragm stops moving. Well, the diaphragm is the pump for the lymphatic system. And that's the primary reason the tonsils and adenoids swell up. It's the disuse of the diaphragm. As soon as a child is mouth breathing and the diaphragm isn't moving up and down, it's the up and down motion of the diaphragm pumping out the lymphatic system that drains the tonsils and adenoids. When the diaphragm stops moving and we're breathing with our chest because we're mouth breathing, if you don't pump your lymphatic system, the cul-de-sac at the end of this is the tonsils and adenoids up, way up. They're not pumped out, they fill. And when those get bigger, we now have another gallon of gasoline on the fire that was already started. So the problem is that swollen tonsils and adenoids are a symptom, not a cause. And that also fits with removing them is very unsuccessful. There's a very low percentage of success in removing tonsils and adenoids and having a child come out of their sleeping and breathing conditions. And the research shows that it is wildly unsuccessful because taking out the tonsils and adenoids, that's a symptom you've removed. their anatomy is still too small to be a nose breather.
Yeah.
When you take them out, they remain mouth breathing, so they grow back because the diaphragm's not moving. They're
Well,
going to
there's
fill
so
right back
much in
up.
that. I got to unpack some of what you said. So
Woo!
there's a lot. So I'm going to try to go back and unpack some of it. And I know there's some ENTs like I've had Stanley Liu on and David McIntosh and some guy and David McIntosh, I know he would adamantly disagree with what was just stated about adenoids and tonsils have nothing to do with the breathing issue. So
Oh,
he
no, no, no. That's not what I said. I didn't say they have nothing
wait
to
that
do.
they don't cause so
They're not the cause of the breathing
but
issue. They
he would
can make
disagree
it
with that.
worse.
So I know
Your
he would
breathing
disagree with that.
condition, you had your breathing problem first. It's becoming the mouth breather first
So
from the
what
early
is
soft
causing
diet.
what would make you breathe through your mouth if your adenoids and turbinates are not enlarged?
Underdeveloped jaws is the primary reason you breathe through your mouth. As soon as you have an early soft diet and your jaws aren't growing, you can't breathe through your nose because you have nasal airflow
Okay,
resistance
so
from the
you're
smaller
saying
nose.
that the structural
Yes,
change of the nose from small jaws, which I believe that's an issue too. But there's some studies showing resident viruses in some kids, like one kid can get a cold,
oh, sure.
they clear it. Other kid,
Yes,
same virus, neighbor kid gets the cold. Those flipping adenoids just never go
yes.
down. So you can have resident viral load, which can cause hypertrophy. They just did they just do histology studies of what they take out. To your point, though, it's like this is what's so hard about
It's a
all this.
vicious
It's
cycle,
a
but
vicious cycle. And what you're saying is absolutely correct. When you have small jaws, but what's causing the small jaws? Well, what causes small jaws is if you're not chewing the right foods in the first place, you're not eating the right foods in the first place, you're atrophied of the muscles, you're going to get smaller jaws, you're going to get a vaulted palate potentially, and TPs up into the nose,
no room for your tongue,
no room for the
posterior
tongue.
displacement.
This is the part I want people to understand. It's like there's
Well,
so
there's a
much
starting point.
involved. There's so much involved. We have to have a
Yeah,
better diet. We have to be
right.
breathing properly. I want to go to the nose too. There's over 40 different functions that the nose has for breathing. The mouth
Mhm.
has zero.
Nothing.
And like you said,
Wildly unhealthy.
it's wildly unhealthy. The other thing we do know in literature has been posted that nasal breathing has an effect on sympathetic tone. And
Hmm.
there is this nasal cycling that happens between the right nostril and the left nostril. So, you breathe out of one side. Most people, 80% of people have this typical nasal cycling where they breathe through one side, the other side rests. Then they breathe through the other nostril. The other side rests, recovers, recuperates. All the cilia is moving everything and recovering.
Oh,
So that
yeah.
nasal cycling. And one side of the nose can correspond to more of a sympathetic tone and then parasympathetic, sympathetic, parasympathetic. It was an interesting article. I got to find it. But that nasal breathing that for thousands of years yogis and have been saying helps calm your mind, that it does. There is a direct correlation between nasal breathing and sympathetic tone, but
Yep.
also diaphragm, the diaphragmatic breathing, that also affects the vagal nerve. And
Hmm.
that deep breathing where you're doing that deep diaphragm. I mean,
Yeah.
we've got kids bouncing off walls, not
Yeah.
breathing, not sleeping, high sympathetic tone, inflammation, atrophied muscles. It's probably one of the sickest, aside from communicable diseases. Okay, we can go back and look at plagues and different things like that and the flu,
Yeah.
but just from a more holistic, remove all these
Very
external,
unhealthy.
we have very unhealthy children today.
Yes.
Very.
And breathing is your number one fuel. Oxygen, airflow,
Yes.
oxygen, carbon dioxide, and nitric oxide. Balancing those three is your number one fuel for a human being. Your second fuel is going to be water. You need liquid. And your third fuel is going to be food. But if you don't have the first one right, it'll affect every system in the body. So each one affects you differently.
Yes.
And you can have an imbalance in some of them for periods of time, but it creates unhealthy downstream, beginning with the airflow. So just to be clear, because I know I don't want to offend the ENTs, but I want to be clear on my stance that the early soft diet is, again,
Yes.
by anthropological research worldwide, the
Yes.
cause of underdeveloped jaws. That's not a disputable thing anymore. The
No, it's
anthropology
not.
research is worldwide accepted as I'll go with undisputable research that shows early soft food is what brings a culture their malocclusion or underdeveloped jaws. So early soft food, underdeveloped jaws. As soon as you have a smaller maxilla and mandible at that first year of life, you have nasal airflow resistance. You're going to be a poor nasal breather before you're a mouth breather. But once you have poor nasal breathing and you become a mouth breather, your mouth breathing is what is going to grow your tonsils and adenoids. The primary reason that tonsils and adenoids are enlarged is a shift to mouth breathing. Number one,
Do you have
being
any
the air tanks
literature for
coming in.
that we could post?
Number
I'll put it.
two, Number two being the diaphragm movement. The diaphragm is the pump for the lymphatic
Yeah,
system. You can pull up any biochemistry, biophysiology textbooks. It's the medical school research. It's not me.
yeah.
But when your diaphragm is the pump for your lymphatic system, when it's functioning properly, your tonsils and adenoids remain empty to keep filtering. But
And
when
we
you
have
have
seen, like Audrey Yoon has posted some interesting, and this is where I'm like, and I don't know, maybe you do have literature supporting mouth breathing, enlarging adenoids and tonsils, but I know what we are also seeing is when you do expansion of the maxilla, Audrey Yoon,
yes,
we're seeing
they
her
shrink.
study, they shrink. So there is
Yes.
something, I think, and even if you may
Well,
not have something right now, I don't know if you do have literature for that, but
physiology textbooks have all this in there.
okay,
The
about the
physiology
adenoids and
textbook. How does
tonsils.
your body work? All you need to know is how does your body work? And then when it's doing it differently, get back to how it worked. So
Yeah.
technically, it's not the expansion that made the tonsils and adenoids shrink. It's the nasal breathing that did. The expansion gives you your ability to breathe through your nose. As soon as you start nasal breathing again, your diaphragm starts to move again because nasal breathing regulates your carbon dioxide level. When you have the proper carbon dioxide level, that's where you get your signal from brain to
Yeah.
diaphragm. Carbon dioxide rises, brain tells the diaphragm to make it lower. So it's the carbon dioxide level. Mouth breathing drops it too low to get the signal going. So yes, expansion helps the tonsils and adenoids shrink, but there's more in there.
And
Expansion
there's
gives you
more
back your
to
nasal
it.
breathing.
Yes, it's the
Yes.
why behind
Expansion
it.
will give you back your
Yes.
nasal breathing. Nasal breathing will give you back your shrinkage because of the diaphragm activity. So my point about the tonsils and adenoids, they are not a cause of your breathing problem. You have a breathing problem first in order to become a mouth breather and shut off your diaphragm to enlarge your tonsils and adenoids. This is the primary reason. In the bell curve of life, you have all the outliers. In a second, I'll get to those, which you mentioned. But the primary reason is the early soft food, the weaker muscles, the underdeveloped jaws give you your change to nasal airflow resistance and mouth breathing. With the mouth breathing comes the diaphragm disuse, and now you've got your tonsils and adenoid growth. What your tonsil and adenoid growth does is it makes your already existing breathing problem worse. I referenced it as you're adding a gallon of gasoline to an inferno that was already started. Now, the research shows both ways this to be accurate. Number one is when you go ahead and you expand and give the room back, if you get the nose breathing again, they shrink. I've seen it for 2 decades in my own
Yes.
office, but Audrey Yoon has published papers.
Yes.
We all know now that, yeah, if you get back to nasal breathing, it shrinks. Dr. Guilleminault did this at Stanford. Dr. Guilleminault's paper is establishing nasal breathing as the ultimate outcome. I think it's the title of the paper out of Stanford. The ultimate outcome for treating a child with OSA is nasal breathing. So he knew it. If you get the nasal breathing back, your tonsils and adenoids will shrink. So expansion gives you back the room to nasal breathe to get your breathing in order. Now, when your breathing is in order, the tonsils and adenoids shrink. I've seen this over 2 decades. Here's the other pattern. If you remove the tonsils and adenoids, taking them out, there's nice research on that showing very unsuccessful. So I would be curious for the ENT to explore that a little more because according to the research that I was taught, that has a low success rate, like 27% for kids in that OSA category. In
I was
fact,
just going
it
to say that
appears
it's about, depending on
most,
the studies that you look at, it's anywhere from, 30 to 70%, and unsuccessful alone.
yeah,
So
alone. And
alone.
the other point is that short-term success isn't success because it's 2/3 of the kids that have their tonsils and adenoids out will revert back to and have worse AHI and OSA scores at 36 months. So 2/3 of the kids are going to be worse than they were at the starting point when they're tracked over 36 months. So I'm more interested in the longer term. The longer term research on tonsil adenoidectomy shows it's a failure because most kids are going to be worse off than they were. And the reason is you took out the tonsils and adenoids, not the cause of the problem. The undersized airway kept that child a mouth breather. And when they're a mouth breather and your diaphragm's not, they grow back. And when they grow back, you're worse than you were to begin with. So in every direction it points to, the tonsils and adenoids aren't our cause. They can make your breathing worse. But when you treat those, it's just like treating the teeth laid. If you want to do braces at 12, wildly unsuccessful. You want to take tonsils and adenoids out as a treatment for the cause of breathing problems, wildly
Well,
unsuccessful.
I think
That
all
is
the
not helping a
literature
child.
is pointing right now to at least what, when we're doing the diagram of what is working, what isn't working. Right now, it looks like you might need both. And I know for my kiddos, two of my three
Ah,
needed both expansion and one kiddo
yeah,
I did TNA first removal, then did expansion. Then I had this guilt of, oh man, I should have expanded first. Maybe he wouldn't need the TNA removal, which is possible. So this is where we're seeing we
yeah,
don't know which kid it's going to be
right.
suffice. So here's the thing. You might need both. My youngest, Judah, he needed both. I did 2 rounds of bony expansion on him. His freaking adenoids were so huge still even after that. So Audrey Yoon's paper, great. I bet you if you would have thrown my kid in there, they wouldn't have shrank. But
Yeah, and I can share my experience there too.
it happens. It happens. But this is the beauty of collaboration.
Yeah,
Sometimes you need both. Why not start with expansion? Because here's the other thing. You've got a kiddo with upper airway resistance syndrome. They don't even have frank OSA, but they're
mhm,
still mouth breathing, right? And it's a problem. And the ENT
yep,
goes, look, I'm not comfortable. These are grade 1 tonsils, grade 1 adenoids. I don't want to do anything, or maybe grade 2. It's suspect, but not
sure.
enough for me to risk surgery because there are risks with surgery. Hey, dentist, orthodontist, do your thing first. Because bottom line is they have a
Hmm.
malocclusion. We need to do our job as a dental healthcare provider, and we need
Yeah,
to correct the hiccup and get in there. What if that was all they needed? So us
yes,
getting in there first,
less invasive.
less invasive, and then you've
You
got
have
the
to do it
what if.
anyway.
And I always tell parents, I don't want to promise you that just because I do
Hmm.
the expansion, your
Right.
kid will never need those adenoids out. Because if they're one of the kiddos that have resonant, I mean, no matter what, their adenoids are a class 4. I can't help. I mean, they just need to get them
Mm.
out because it happens. But I, all the literature is pointing to tonsils and adenoids alone doesn't
Hmm.
seem to be the answer. It needs to, because we're not really getting to a lot of the why behind some of that. So it's like
Doesn't treat the cause.
yes. So we have to work as a team and collaboration, and especially these young kids where you can make the most impact and you're not really, maybe the parents are nervous about a surgery or the ENT is unwilling to
Yeah,
do a surgery. Then it's like, hey, we're over here. Work with your dentist, work with her. And I'm going to say something Stanley Liu said. Stanley Liu
yeah.
is amazing. He's at Nova now. He's great.
He's the best. Yeah.
He's the best. And I have a little video footage I threw out when he said this because I was like, wow, this is great to have someone like him say this. But, he looked at Tracy and I and he goes, who is the ENT, if you will? Who is the one that can affect the nose the most in a young child? Because we're not going to do surgery on a nose.
Mm-mm.
Who affects the flow? Who affects the shape of the nose in a young child? It's your dentist. It's your
It's the
orthodontist.
dentist.
We are
Yeah,
the ones that can affect what, like you've been saying, we can get that increase that
yeah,
value. And like the importance of what you're saying, myofunctional therapy, sometimes you can open a nose all you want. And the ENTs will tell you this, whether it's opening the nose through surgery or whether it's opening the nose, removing an obstruction, whether it's
mm,
polyps, deviated septums, turbinates, adenoids, whatever. Or it's us doing expansion and we improve nasal volume. Sometimes they need that myofunctional therapy because, like Christian Guilleminault said, the nose has been turned off. And you
yeah,
have to teach them to turn their nose back on. There is a sensory input to the brain. And if it's been
yeah.
depleted and atrophied, they have to learn how to use that nose again. So the importance of myofunctional therapy and the
Oh,
exercises,
yeah,
an additional appliance with exercises to teach them to do that is so important. And it's
yeah. And
multifaceted.
growing the jaws, getting the size right is tremendous for space to breathe through. But you
Yes.
not only have to retrain the nasal breathing, you also have to retrain the musculature to behave itself because your lips, cheeks, tongue, all the facial muscles have been behaving badly to give us this underdeveloped jaw structure. Muscles are very repetitive motion, so they do the same thing afterwards. That's the reason for relapse, is when you treat the teeth only and you relapse is because your musculature was weak inside, strong outside. You
Yes.
collapse back in. Just because we give them the size doesn't mean we're done and it's big and beautiful and all the teeth fit. Now you want your myofunctional therapy because you want your tongue living in that space appropriately, resting appropriately, up in the mouth, roof of the mouth, and then functioning properly. Now, getting back to the tonsils and adenoids, I'll share my 2 decades and give you the kind of the full picture. Like I said, a bell curve of where nasal breathing can go south. Primarily, the largest category is going to be underdeveloped jaws because almost every child has the early soft diet and the underdeveloped jaws. But secondarily, you mentioned other things that are out there in the environment. Yeah, you could have an allergy to something. A child who is nose breathing, who has enough room that they are nose breathing, you could bring a pet into that house that they're allergic to. A cat. Now they can't breathe. Their nose is stuffy all the time. They breathe through their mouth. Their malocclusion, which might have been mild, will now be
Yeah.
severe.
Yes.
So the point is, we don't see children grow full jaws and 32 teeth on their own. That is a unicorn today.
It is.
So you could almost say every child, I'm going to say almost every child is underdeveloped jaws. Whether
Yeah.
you are a mouth breather or not, most are. Some retain a little bit of nose breathing, but introduce a birch trees in the front yard could do it. A cat could do it. A hamster could do it. Getting like a virus, all of a sudden your nose got closed off. That was the last straw. It wasn't the cause. It was the last straw. You have the underdeveloped jaws already there. My experience with tonsils and adenoids, almost no child needs them out. So my experience is 2 decades. I'm going to share it with you now. It's 1 out of several hundred out of my office need them out. And here's my reason. I'll give you my reason, which I believe is accurate, but it's 2 decades to show for it. I only use an upper and lower expander, a set. I do not do upper only. So now, we already know about taking the tonsils out as a standalone. Doesn't seem to be doing very much for the kids. That's a bad choice, it seems like. They're going to grow back most of the time. But now let's talk about expansion. My end of things, I do upper and lower expanders. I bring those kids to a size that is appropriate by research, McNamara to Bogue. You can go back to Bogue, the pediatric guy who knew the measurements then in the baby teeth.
Yep.
He knew if your baby teeth are spaced by a nickel's width, you would have good adult teeth. But we don't have nickels fitting between baby teeth. But when you have that, then you go back a little further and you go anthropology research because malocclusion doesn't exist in cultures that have early hard food. Jaws are fully grown. You have measurements. We know what those jaws measure. We know what it takes to fit 32 teeth in 99.9% of the population. So now you have these measurements. I use an upper and a lower expander because when you use both, you can take the jaws to the right size. When you have the right size, you do get your full nasal breather back. You add the myofunctional therapy so the muscles behave themselves. Proper expansion plus a little bit of myofunctional therapy equals a nasal breather, which means in my own practice for 2 decades, only 1 out of several hundred kids gets their tonsils and adenoids out. It's a fraction of a percent, because once they're nasal breathing, they will shrink. And now I can look at a different category, upper expander alone. And so I understand where you're coming from, where you say sometimes they need both. I'll tell you the failure and base it on the research out there. There was a lot of research done on early treatment, early intervention, early phase orthodontics. And they did a lot of research. I think no less than 32 individual published papers showed that it's a failure. It's useless. There's nothing to gain from it. Going back decades, the orthodontic specialty shared this is why we don't do it early. Because like you said, dentists and other people, way back when, like 100 years ago, Dr. Engel was arguing for early intervention, grow the jaws, keep the teeth, right? He was an expansion guy. The decades of the research that showed early treatment doesn't work was because you did all this research, you did all the work, you treated this younger child, but what happened when you took it away, they relapsed back to the start. When they're 11, they're in the same starting point. Why should we do something early and then have to do it again at 11? We're starting over. It didn't make sense. We shouldn't do early treatment. It's not indicated. So you have all of this research that shows early treatment is ineffective. Dig into it a little bit. What techniques were used? Well, it turns out almost all of that early treatment was an upper expander alone. A more accurate conclusion, in my eyes, is upper expanders alone are useless. Upper expanders alone, like tonsil adenoidectomy alone, not successful. Now, the upper expander alone technique, you cannot go very far.
No.
Because when you put an upper expander alone, you can have 2-3 millimeters, on rare occasion, maybe 4. But you can't push the top back teeth wider than the bottom teeth and have that scissor bite. That's
And
bad.
that used to be taught. It used to be taught. So for those that don't understand, like it used to be taught up, you can expand and let's, they would do either a little RPE or a little Schwartz or slow, whatever.
Yeah.
But they wouldn't do anything on the lower because they said, the lower jaw follows. It doesn't.
No,
So
it
all
doesn't.
what they're saying
That's a myth.
now, that's a myth. And now we know on average, if you leave the lower jaw alone, it might upright maybe about a millimeter.
Yeah.
That's not
It's
enough. That's not
no.
enough.
And we know from waiting until the kids are 11 or 12, their lower crowding didn't go away. The lower inclination didn't go away. The
Yes,
lower
all the
jaw isn't, they're not, the teeth,
compensations.
yeah, the tongue is not working, so your lower jaw is not growing. The lower jaw grows by the tongue's activity, not our genes. And so when the lower jaw is growing appropriately, it's because your tongue was working properly. So the point about doing an upper expander only, if you only go a few millimeters on top, the moment you take it out, it's going to shrink back to match the bottom. The relapse is instant. Upper expander only, it gives you a short temporary improvement in nasal breathing because it's a 2, 3, 4 millimeter maybe. Those few millimeters, you can have a child improve a little bit of nose breathing, but once you take the expander out and they go back to match the lower arch, the nasal breathing isn't there, the mouth breathing begins. So I have seen over 2 decades of kids who have had a history of upper expander only have nothing to show for it. They have no gain in their
Yeah.
width, they have no gain in their symptoms, they have no improvement, which is the hesitation again of the ortho community to maybe say, we can help with your breathing, we can help with your sleeping. No, they weren't taught how to do it like you mentioned, but also the upper expander alone doesn't improve your breathing, and then the relapse brings it right back.
And then the
So
other debate out
I,
there with upper expander is, okay, and this is what's being talked about a lot right now, are you
yeah,
getting skeletal changes? Or are you just getting more dentoalveolar? What are you trying to accomplish? Like, are you
oh, all
just,
skeletal. The
you
younger the
know,
better. The younger
yeah,
the better, all
the
skeletal. I
younger the
use fixed
better,
expanders through the
skeletal.
teenage years. Yeah.
Yes.
It's
Yes.
skeletal all the way through the teen years, and you can even have skeletal in the adult, which is a whole nother third rail to touch. But the point about treating a child earlier, the better, is to get the skeletal growth of both jaws.
Yeah.
And with both expanders, you not only get the nose back, but you need the tongue space too. Because if you just do an upper expander, it's not enough to get the tongue in place, and then you can't get the air behind the tongue. So you might improve a little nasal breathing, but if you can't get the air behind your tongue, you're still going to become a mouth breather again. So the upper expander only is a failure by the research. Calling it early treatment isn't successful. Early treatment is useless. Early treatment doesn't work. That's a bad way to describe that. We look at
Right.
the research and we know, number one, upper expander only, not good. Number two, no myofunctional therapy was
Right.
done. And if you don't
That's
do
that's a
myofunctional
huge component.
therapy,
Christian Guilleminault has the best outcome
you
was
can't, yeah,
expansion, myofunctional therapy. He did throw in
right.
tonsils and adenoids,
So
but
I'll give you the grade. Yeah. So like in grading things out, in my world, a child has to have an upper and lower expander if you're going to do expanders, because it's the only way to give them the right size to become the nasal breather and include the myotherapy. So when I say 1 out of several hundred kids needs their tonsils and adenoids out, it's because of the upper and lower expander technique and including myofunctional therapy. And then third on that list is frenum releases that are indicated, because there's a large percentage of kids that need frenums released, whether it's 25, 35, 45, 75, whatever you believe, but you've got all these frenum to take a look at. And any tightness in frenum does affect the musculature and the
it
breathing.
sure does. It's a fascial
So,
constraint. I mean, you
yeah,
are not allowing growth and development if you have
yeah.
muscles that are just so tight and just the
So
fascia won't allow the growth.
in my world, the child who gets upper and lower expanders, myofunctional therapy, and necessary frenum releases, that's when you have a fraction of a percent will need tonsils and adenoids out. That's 2 decades of me doing that. And then if you want to have more tonsil adenoids removed, take away the frenum releases, the percentage will go up. Take away myofunctional therapy, the percentage of tonsil adenoid removal will go up because they're not going to shrink as much. Take away a lower expander, and we already know what happens. An upper expander, the research shows, is near useless according to the published data on how successful that is early treatment. The worst possible thing for a child is an upper expander only. That technique alone, awful.
Well, what
And
we're
so I'm
also
not a fan
finding
of,
too, there's some new, my friend Reza Movahed is coming out with some interesting stuff with adults with a new device to actually get a little bit of surgical intervention and distraction,
yeah.
expansion of the lower jaw. What is going to start coming out, and it's interesting, it'll be interesting to watch, but just even that upper moving the lower jaw also affects the muscles of the airway as well, which we don't have any research on. Everything's
Right.
about the upper jaw with the base of the nose and the soft palate, right? And even even the sagittal aspect with the soft
Hmm.
palate moving forward, but the transverse with tightening those the soft palate as well as a base of the nose. But no one's really looked at what is happening with the muscles when we actually expand the lower arches too, which
Yeah.
they'll argue you're not really getting expansion of a lower jaw, you're getting uprighting of the teeth. However, I've met some orthodontists
Mm.
who will tell you that, if you get a good Schwartz in there on that lower and or you get in really young, you can do a little expansion of that mandible.
Yeah.
You can widen the mandible. Again, not a lot of research. This is again
Yeah.
anecdotal, but this is
Right.
part of this is how things change is we have these conversations and we talk about it.
Sure.
But having the younger you get to the child,
Younger the better.
you can have skeletal changes with very little external movements. Because what is nature's expander? The
The
tongue.
tongue.
So if a tongue can grow a face in a young
Hmm.
child, then the sooner we get in there and get that tongue working, and you don't
Yep.
need all these crazy hard mechanics in a young child, which is the point.
Gentle and slow.
Gentle,
Yeah.
slow, rhythmic. That's how the tongue
Yep.
works. So
Cycles, cycle,
it
pressure, and
cycles.
tension, you grow bone. And that's what the tongue
Yes,
does. But provided the tongue is functioning properly. When it's not, of
correct.
course, we're not going to get lower jaw growth.
Correct.
So the lower expander is not the end all be all. Everybody keeps saying, oh, you can't grow, you can't expand the lower jaw. You can't. It's a sequence of events.
Yes.
Number one, we're using a lower Schwartz. It could be fixed or removable, but it's the technique that's more important. It is a really slow pace because you give a little signal, then you don't. You give a little signal, then you don't.
And
It's
then
why
you
you
don't.
turn it. That's why you activate it once or twice a week. The lower just needs a once or twice a week, a little activation. Give the bone a signal, but then take it away. Give the bone a signal, then there is none. Cycles of pressure and tension grow bone. What you're doing is you're mimicking the tongue to give a little
Yes.
signal, then not. Don't keep cranking the lower. It's a different bone. Slow turning pace. You're getting growth. I'm going to say growth. I like the word growth better than expansion.
Yeah.
So growth, not only am I going to get my growth, but I'm going to get a beautiful amount of upper and lower growth. Now I have the proper chamber for the tongue. And the moment I have that, I'm taking out that expander so the myofunctional therapist can get that tongue right.
That tongue
Because
up.
that's where you really get the growth of the jaws. You want the upper and lower jaw growing, and you can have catch-up growth. There's nothing wrong with having catch-up growth. Just because we jumped in at whatever age it is, the tongue can help you get more. So yes, the lower jaw is growing when you use a nice expander, fixed or removable, appropriately, and you get the tongue working for you afterwards. Just because the ortho research shows you can't, do anything with an upper expander only doesn't mean expansion doesn't work. We just haven't done it yet. And so
Correct.
2 decades is a long, and believe me, I waited 10 years before I taught anybody this. I did 10 years of this, which is thousands of kids, before I even thought of maybe I should share it with someone else because I knew what was happening in our own practice. And when you do one after the next and it's working very well, you keep going. So sure
Hey,
enough, it took
20
me 10
years is
years.
nothing to sneeze at. And that's,
It took me 10 years, thousands of kids to feel comfortable. Now let me
yeah.
teach other people because again, nobody was doing this. And then a step further is when you grow both jaws, like the icing on the cake for the kids, not only are we getting the breathing back because I gave them back the nasal chamber and the tongue space. Now the myofunctional therapy gets the muscles right with their new home. In the end, that child keeps growing. And most of the kids that we treat have their wisdom teeth come in. So most of the kids, and you mentioned it earlier about how the wisdom teeth can
Yes.
fit, proper expansion early, get your breathing back, get your muscles in line then, keep growing, and you keep your wisdom teeth. So most of the kids that we treat have no symptoms. They get their nose breathing back, they lose the list of symptoms that came with mouth breathing or worse, and then they get to keep their wisdom teeth. And I know we touched on it a moment ago about like OSA, having OSA, but one thing I like to teach the parents about it, because a lot of people don't even understand the difference between nose breathing and mouth breathing and how severe it is.
Yes.
But a lot of people focus on OSA. Oh, the kids don't have OSA. It's like
Yep.
3%, 5%. That's accurate. I understand obstructive sleep apnea might be 3 or 5% of the kids, but I'm telling you 99% of them are unhealthy.
Yes.
I like to give a parent this grade to think about. I refer to OSA as a stage 4 disease.
Right. End
That's a
stage
stage 4.
disease. Yep.
It's the worst you could be. It's the end stage disease. It's the worst you could be. Nobody wants to wait till you're stage 4 to treat. How about stage 3, 2, or 1? Well, with OSA being compared to like a stage 4 disease, you know what it makes mouth breathing? Mouth breathing is your stage 1 disease. And the moment a child has their lips apart, even a little bit of the day or night, they're unhealthy. It throws off how they're being fueled. And welcome to dysregulation. In one way, you could say loosely, they're malfunctioning, but it is the mouth breathing that throws off their ingredients getting into the lung and shared to the body, and now they start to malfunction. So I teach the parents about stage 4 versus stage 1. You don't wait till stage 4 to treat a child. Just because they don't have OSA doesn't mean they're healthy. You got to work on mouth breathing, which is grow the jaws. The difference between nose and mouth breathing, I tell the parents, look, your child is a high performance race car. Ferrari, Lamborghini, whatever you like. Your child is a high performance race car. Do you know that high performance race car, in order to perform at its peak performance around a track, has to have a specialized fuel? Well, that specialized fuel for your child is nose breathing. But if you took that high performance race car, whatever your favorite one is, and you put in a regular, just average low grade gasoline in it, it'll get on the track and go around, but it will not have peak performance. It will struggle, it will malfunction, and it will basically then break down sooner. That's mouth breathing. Mouth breathing is putting in the wrong fuel. So nose breathing, mouth breathing, opposites, wildly unsuccessful to be a mouth breather for a child. And sure enough, the list of unhealthy is everything. I mean, it's any symptom you could name, I could tell you mouth breathing is related to it. It might not be the only reason, but any system in the body that's failing, whether it's the child's behavior, whether it's the bedwetting, the ear infections, the nightmares, the night terrors, the performance at school, the digestive system, the nervous system, the circulatory system, whatever the child might be struggling with, there's a connection to their breathing, and mouth breathing is a pathway to become
So
unhealthy. And
much,
so,
so much inflammation, so much with
oh,
mouth
the
breathing.
inflammation is crazy. The sympathetic
Inflammation
nervous
is,
system.
yes, it is. And I had
Yeah.
recently we had Dr. Robert Lustig on, Dr. Alan
Yeah.
Reisinger on. I mean, these guys are at the ADA talking about Dr. Nathan Bryan with nitric oxide.
Yes. My
Um,
favorite. I
and
like these guys.
these guys are big
Good
hitters,
people.
and they're like, hey, folks, you need to work with your dental community because
Yeah.
we all have to start working together to help these kids. And there's a lot. And really it starts with diet. And we live in a country with some of the
Yeah.
worst regulations and
Oh,
what is allowed to be on the shelves and how we're
yeah.
educating even God love our pediatricians. They're inundated with so much to do in these big healthcare systems, and they're barely have time to even ask the questions they want to. But, they're at the mercy of what they're taught in medical school. So hopefully we get in dental school residencies for
Yeah.
specialties, we start getting some change so we get different practitioners out beating the same drum that we're all saying right now. I know you have to go
Oh,
soon,
man.
and I really stunk at cutting it off fast.
No, no, totally fine. This is
But
so
I
valuable in the
want to
work that we're
say
trying to
to
help kids.
we are trying to help kids, and I do appreciate everything. Like we all have to work together. We're talking to the same people. We're trying to educate the same population, and the more of us
Yeah.
saying this, the more people are going to start asking questions, demanding this kind of care for themselves. And I've got in the links for everybody, like information on airway health solutions that you're a part of and tooth pillow that you're a part of and started. I have links for airway. So if you go to the airway health solutions link, you'll be able to register for the airway palooza, which is this October 17th. Is that right?
Yeah, I think it is the weekend of 16, 17, 18, or 17, 18, 19 in
Okay.
October. And like you mentioned, that's a collaborative effort. We have
It's
the medical
collaborative.
community there, we have the dental community there, we have the myofunctional therapy community. We pull everybody together to have a celebration of, hey, what are the, current ideas and how do we help more kids? Like that's bringing everybody together to,
That is.
kind of learn and play together.
Yeah. And look, what we're talking about today, a year from now, we could take this, build on, and have all new information. So that's what's so important about staying plugged in and
Yeah.
listening is this is all changing so fast. And the
Yeah.
information is just pouring out like a water hose. And it's so stay plugged in with people in your community, keep the conversations going. And Ben, I have three random
Yeah.
questions that have nothing to do with anything. Okay, one, if you could time travel, where would you go?
Oh my goodness, time travel. Oh
That
wow.
wasn't a really short one. I mean, that's kind of a deep one, but
It's a tough one. The first thing that popped into my head, I probably would go maybe ancient Rome and to go explore the Colosseum when it was being used.
can you even
I'd love it.
imagine? I
I'd love
mean,
to see that.
Yes, and just the
Yeah.
crowds and I mean
Oh,
some of
just
the stuff that they were watching we probably don't want to watch,
there are
but
so many things. That's a long list, but that popped into my head because visiting Italy is always nice. But I would
yeah,
like to be there in the real time.
I love it. That's great. What was your favorite job that you had before you became a dentist?
Before I became a dentist, I was a builder with my dad and my uncle.
Where are you?
So I started around age 12 years old as soon as I could carry stuff and be productive on a construction site. So my dad and my uncle were, building houses and doing construction. And I went and did that from the time I was 12, really even after dental school, because I joined a practice that was fee for service and you had to build your clientele. And so I was still doing things like decks and kitchens and roofing and basement, and I can basically, yeah, build anything. But I love carpentry and I love building stuff, and I did it for 18 years. I don't think I quit till I
Wow.
was 30. So I have 18 years experience building
I
stuff.
had
And
no
then the
idea.
overlap. Well, you go to dental school. I worked my way through high school and college and
Yeah.
dental school doing that. After dental school, you did a residency. I did that on the weekends. And then after that, starting a practice, it was 1 day a week, then 2 days a week, because I had to grow. It was not an insurance practice. I had to grow a clientele. Well, the other days when I wasn't working and there weren't patients to treat, I went and followed my uncle and my dad around and did whatever they were building at the time to make a little money to keep it rolling and pay a little debt. And, basically I was doing that as it transitioned. And as I was too busy being a dentist, I had to give up the carpentry.
Good for you, man. I wish I had that. I got a storm door right now with the handle that keeps falling off and I don't know what to do with it.
Oh, I'll fix that for you in 5 minutes.
Sounds
That's an easy
good,
one.
Ben. Sounds
That's
good.
an easy one.
Last one. What's the last song you listened to?
The last song I listened to. Oh, I know. I was in the car this morning and I went out but I had on the sports talk radio.
Okay, well that counts.
Oh my goodness. So I usually listen to classic rock, hard rock. Yeah, I like Van
Oh
Halen
yeah.
type Guns N'
Wait,
Roses
which
and
Van Halen? David Lee Roth or Sammy Hagar?
yeah, David Lee Roth. I'm a David
Okay.
Lee Roth fan. So the younger,
Okay, jump,
earlier
all
Van
that.
Halen, big Eddie Van Halen fan. So I usually have on a classic rock station and they would play anything from Motley Crue to Guns N' Roses to Van
Oh
Halen.
yes, Motley
To
Crue.
be honest, I don't know what the very last of those songs I heard, but I flipped between sports talk radio and we have I-95 here, which is like the classic rock channel. It's a classic rock song or it's sports talk.
I love that. I love it. Well, I love getting to know a little bit. I had no idea that
Yeah,
you are a
surprise.
builder. Yeah. How amazing. How amazing. Well, thank you for being here today. And you're building, healthier kids and healthy smiles. And we appreciate all that you've done over the last 20 years to promote this because it takes all of us together to share this message because it's not being talked about enough. So thank you for all you've done, Ben. And you were,
I appreciate that.
integral in my early journey as well. And for that, I thank you. And maybe we'll have you back for like a part two because there's a lot to say. So,
There's so much to talk about. I would come back
so
anytime. Thank you very much for having me. I really
absolutely.
appreciate it. Thanks for spreading the word and sharing the message and doing everything you're doing because it really is going to take all of us to help all these kids. We need everybody doing this, not just a few of us.
Absolutely, friend. All right, everybody. We'll see you back
Yeah.
next time. Thanks for joining us.